Welcome to the University of California, Davis Health System. Since 1973, continuing medical education, CME, has been an integral part of the educational mission of the UC Davis School of Medicine and Medical Center. The Center for Health and Technology, CHT, increases access to health education and promotes interaction between patients, physicians, and other healthcare professionals through the use of telecommunications and computer technology.
Good afternoon. Welcome to the You Asked For It teleconference distance education class. Our topic is Disaster Mental Health Just-in-Time Training. I'll be providing an overview about the philosophy of disaster mental health, characteristics of disasters, coping styles, anxiety reactions, post-traumatic stress disorder, mass casualties, and an overview of the disaster mental health modules and a list of resources. Now, it's important to remember that disasters touch all of us in different ways, but everyone who's been through a disaster is touched by it. And again, even though there are differences for individuals, there are also commonalities that exist in how people respond after all types of disasters. Initially, the survivors are in need of practical rather than psychological help. It's important to remember that disaster mental health is not psychotherapy. I'll be touching on some of the differences later. Many of the emotional reactions stem from practical problems that are caused by a disaster. It could be very simple things like finding out where to go to file paperwork with FEBA, or where to go and find food or some extra clothing for yourself or your family. Disaster mental health has to be flexible. It's based on the needs of the survivors, the family members, the rescue workers, and the community, and the type of disaster that's occurred. We have to recognize differing cultural and religious beliefs at the disaster site and in the community. Disaster mental health recognizes and uses community resources as much as possible. An example of this is that the City of Davis has just put out a request for volunteers to come in and take classes for disaster training. It covers Red Cross disaster courses, but it also includes learning basic skills that could be used in a disaster, like making sandbags and directing traffic. And again, these people would be called on to stay within Davis and work in the community in the event of a disaster. It's also important to remember that no one works alone at a disaster site. Teams work in shifts. And this is an example of Red Cross volunteers at a site conferring. Team leadership is based on experience and skill, not the profession. So whoever's had the most experience at disaster sites is the head of the team. It's very important to have good handoffs and have an ability to collaborate. And there should be frequent opportunities for team consultation, not just among members of a team, but between teams also. And early interventions focus on protection, safety, and again, promoting that sense of security for the survivors and for the people in the community. There's a hierarchy of needs. The first, of course, is survival, getting through the disaster and being able to say, I'm here, I'm alive. The next concern then is safety and security. Am I safe? Is my family safe? Is my home safe? And then there's food, clothing, and shelter, and then finally health and well-being. One of the philosophies of disaster mental health is to return individuals as much as possible to their pre-disaster level of mental health. And therapy is accomplished by walking around, providing human contact and assisting in problem solving. It's addressing crises in manageable doses, what that person wants to talk about for as long as they want to talk about it that day, and then brief assessment and follow-up over several days. So it's a matter of going back to the person who is having the problem and talking with them and saying, did you get that problem solved? If not, here's a resource that can help you with that. And mental health services need to be available for everyone over the short term and the long term. We're learning this now after 9/11 and also especially after Hurricane Katrina, that there are still people needing plenty of mental health services, and it's not always available to them. Now, there are different factors that can affect post-disaster pathology. There's the degree of exposure to the disaster. And that could be different from someone who was a victim versus someone who was a first responder and someone who comes in later to the site to help rescue people. There's also the size and scope of the disaster. How long does it take for recovery to begin? How long are daily activities disrupted? And has this type of disaster occurred before? If the disaster has occurred before, say flooding, then the community has resources online and they know how to deal with it, and they know that, okay, this is step 1, this is step 2, this is step 3 to getting the community back together again and getting people back to where they were before the flood. The construct of the disaster is also important, and I'll be touching on that in a minute too. The death toll and the number of casualties can also have an effect on people. And how much of the community is affected? Is it a small area in a large city? Is it a small town where most of the community is affected? Or is it, say, small towns but in a region or a county where many places have been affected by it? Is it natural or was it caused by humans? Or both? And could the natural disaster have been predicted or planned for? Also, was it intentional or accidental, or both? That can have an effect on how people react to what's happened. And existing pathologies, such as personality and mood disorders and substance abuse, can also affect pathology post-disaster. This is a photo of someone looking at a listing of names of tsunami survivors from 2004. Now, with terrorist attacks, there are unique features. With biologic and chemical agents, initial symptoms can resemble common illness and go undetected. So it may take time for public health agencies to see a pattern of symptoms in people. Many agents that could be used are not familiar to physicians, and they may not be diagnosed very promptly. And there may be long-term side effects depending on the agent that's used. These are some examples of biological and chemical agents. There's Clostridium, anthrax, Yersinia pestis, which is also the cause of bubonic plague, is more commonly known, and cesium. Cesium played a role in a disaster in Brazil back in the 1980s, where an abandoned medical building was broken into and a piece of machinery for treating cancer was opened up, and cesium was taken out. And the people who took it out didn't know what it was. They saw this bright blue glowing powder and they thought it was just something fun to play with or something special, and ended up taking it home and giving it to friends and family members. And some people got it on their hands, didn't wash their hands, and then ate. And those are the ones who actually died from the exposure to it because, again, they didn't know what it was or that it was toxic, and they got the biggest dose. Now, the danger can persist and exposure could persist, and survivors can require long-term care. Examples here are the explosion at the Chernobyl nuclear power plant in Ukraine and exposure to Agent Orange. Now, with unfamiliar agents, there may be increased levels of medically unexplained physical symptoms. And those are symptoms that seem to have no explanation, but the people are coming into their doctor's offices and saying, I'm going through this and this and this, and I don't know why. Now, these are some slides from Chernobyl. You can see that there's one that shows an abandoned, I think, classroom or building, but people had to leave there very quickly. They could not bring anything with them because that was also contaminated and radioactive. So there are plenty of abandoned buildings there. People are also having to get checkups regularly for long-term care, and we are seeing some long-term effects of radiation exposure coming in now. The picture on the lower left shows a vehicle graveyard. The vehicles there were also highly contaminated with radioactive materials, and those couldn't be taken out of the region either. So again, they were buried and some were just left behind in the open. And the picture in the lower right is probably about all that's left of the power plant. It says Chernobyl on the sign. Now, after a disaster, there are group responses and individual responses. For group responses, initially, normal survival reactions would include a loss of confidence in institutions, anger at authority figures, scapegoating, social isolation, demoralization, strong emotions, and signs and symptoms of autonomic arousal. Short-term responses are 1 week to several months later. These include intrusive symptoms, hypervigilance, insomnia, increased visits to primary care for vague symptoms, anger, grief, irritability, apathy, social withdrawal. And again, those vague symptoms can include those medically unexplained physical symptoms that I just mentioned. Up to a year post-disaster includes disappointment, resentfulness, a weakened sense of community. Abnormal survival reactions include symptoms of arousal and anxiety, a mass outbreak of contagious symptoms with no identifiable cause, and panic. Panic after disaster is usually quite rare, and sometimes people have showed very logical, rational, thought-out reactions, which other people have labeled as panic. An example is during the 3 Mile Island incident at the nuclear power plant. The citizens felt that they were given incomplete information and didn't really answer their questions. So some of them decided to evacuate, and they did so in an orderly, safe manner with no problems or no accidents. Yet some officials called this a panic. And it's not really clear why, but to them they thought it was a panic, but it really wasn't. Anyone who's exposed to a disaster is at risk. There are immediate survivors, family members, friends, rescue workers, healthcare workers, others in the local community, and even television viewers. After 9/11, the scenes of the towers going down were shown very frequently on television, to the extent that some people ended up developing symptoms of PTSD just from watching the footage over and over again. An example of medically unexplained physical symptoms occurred in Tokyo when the sarin nerve gas was released by the Aum Shinrikyo cult. I believe the ratio was about 4 or 5 to 1 for people reporting with symptoms who had not been exposed to people reporting with symptoms who had been directly exposed. So for every person who was exposed to the sarin nerve gas, another 4 or 5 who were not exposed showed up in the hospital saying that they had symptoms and they needed treatment when they really didn't. They were more afraid of what had happened. Now, coping styles will influence how people are responding to a disaster. They're defined as behavioral and psychological ways that people use to master, tolerate, reduce, or minimize stressful events. Now, there are different distinctions in the literature, different disagreements in the literature about this, but what they do agree on is that there's a distinction addressing problem-focused and emotion-focused coping. Problem-focused coping uses actions to alleviate stressful circumstances, where emotion-focused coping uses efforts to regulate the emotional consequences of stressful or potentially stressful events. There's also active versus passive coping. Active coping involves behavioral or psychological responses designed to change the nature of the stressor. So it's a way of saying, okay, I'm going to deal with the stressor by doing something like this. Whereas passive coping involves activities or mental states that prevent directly addressing stressful events. But it may also include activities that provide more information without leading to action. So in the case of rising floodwaters, someone may decide to watch television, which would be passive coping, but if they're watching the news reports to see how high the water level is going, that gives them information to decide, is it time to sandbag my house? Is it time to prepare to evacuate my house? And what else do I need to do? So even though it's called passive, it will lead to active coping eventually. Dangerous coping involves attempts to get closer to a disaster. Avoidant coping involves engaging in activities to get your mind off the disaster instead of taking appropriate actions, and that could be the use of drugs. Both of these strategies can expose an individual to greater danger. And research has shown that active and problem-focused coping strategies produce better emotional adjustment to chronic stress. Also keep in mind, coping skills can be learned. An example of this is my husband and I are working with our 7-year-old daughter who, when something bothers her, will start crying. So we are always telling her, well, you can cry to make yourself feel better, but it's not going to solve your problem. What can you do to solve your problem? And then we help her try and work through some kind of problem-solving method to figure out what to do. Now this is a photo that shows some dangerous coping. Toward the center bottom of the photo, you can see that there are people who are taking a look at rising floodwaters, and you can see the floodwaters in the center of the picture. Now it looks like the floodwaters are going off to the side, down a stream, but there could be a surge of water back there where we can't see that could come down very suddenly on the people and could overwhelm them. There's really, if it's going fast enough, there's no way they could outrun it. So they are putting themselves in great danger by doing this. Another example would be driving out during a tornado warning to try and look at the funnel cloud, because you want to see one. Now, after disaster, there will usually be a rise in anxiety disorders. And these may occur even in people who are coping, and coping pretty well. But the anxiety may present as acute stress disorder, post-traumatic stress disorder, or another anxiety disorder. Symptoms could include chest pain or tightness, fatigue, memory problems, pain, and sleep disturbances. And this is usually how people would present at the doctor's office. They won't say, I'm anxious, or I'm worried about this. They'll say, I have problems sleeping, I'm tired all the time, I have a lot of pain in my chest and tightness. For treating anxiety disorders after disaster, Psychosocial treatment includes education, support, relaxation training, cognitive and behavioral therapy. Medication options include antidepressants, gabapentin, atypical antipsychotics, beta blockers, and benzodiazepines. It's important to screen for PTSD because people, again, will present with physical symptoms rather than psychological problems like fatigue, trouble sleeping. So people will self-treat by abusing substances. Other problems may also come up, such as marital problems, unemployment, and suicidal ideation. Traumatic stress can bring out hormonal, neurochemical, immune system functioning, and autonomic nervous system changes that can affect physical health. And life-threatening medical conditions can cause or exacerbate PTSD, and PTSD can in turn influence those medical conditions. Now, for screening for PTSD, if the disaster was recent and you know the person fairly well, you can ask, were you affected in any way by the recent floods or by the tornado or by the hurricane? And just see what they say. Again, you have to know the person, I think, fairly well to be able to bring it up like that. You can use self-report screens. There's a mnemonic that uses a DREAMS acronym, which is listed in the modules that I'll be talking about later. There's the primary care PTSD screen, which I'll be covering at the end, and also a life events checklist, which is also listed in the modules. Also consider using the CAGE for alcoholism, and I'll go over that at the end also. And ask about suicidal ideation. We usually think that suicide is something that comes up only when someone is depressed, but there's a lot of research indicating that people who are very anxious are also very likely to make suicide attempts. And any anxiety disorder like PTSD or ASD could also impact on this. If a patient needs a referral, suggest a consultation and normalize the idea of treatment and provide handouts about PTSD. And it's perfectly acceptable to say, I think you may have this, but I'm not sure. I'd like you to talk to someone who knows more about this. And then follow up at the next visit and say, did you go to this referral? And don't ask why. That really puts people on the defensive. It's better to use something a little more gentle and say, what kept you from making this appointment, or what kept you from calling this person? And just follow through and see what they say about that. PTSD can be treated. We need education, pharmacotherapy, and psychotherapy. It can all be provided, in most cases, locally. Pharmacotherapy includes serotonergic agents, tricyclic antidepressants, antiadrenergic agents, and benzodiazepines. Psychotherapy helps the patient break that pattern of re-examining the traumatic event. It also provides education, teaches other ways of coping, and helps the patient improve relationships. What seems to happen with PTSD is that the person gets stuck in responding to the stimulus, the trauma, in the same way, rather than learning new ways to respond to it. Sometimes with the PTSD, it can become almost phobic, where the individual wants to avoid anything that even remotely reminds them of the trauma. An example is a patient I saw who had been a bank manager, and the bank was robbed, and during the robbery, she was physically assaulted. A gun was pointed right at her, and her life was threatened. She not only had nightmares about it and flashbacks, she found that eventually she couldn't even drive past the bank branch where this had occurred. And then she found that she couldn't drive past other branches of the bank, even though she had not been in those and had not been robbed in those. She also got to the point where seeing the names of coworkers in the newspaper, or hearing an ad about the bank, or seeing an ad for it in the newspaper also brought back a lot of the trauma. Now, there are a lot of risk factors for PTSD. Having a high number of PTSD symptoms makes you at more risk for developing the full-blown syndrome. Having a hyperreactivity to stressors, anxiety or other affective disorders, comorbid medical conditions, lower socioeconomic status, being female, and being single can also have an effect. Another risk factor that I didn't include on here is also being through other traumas. It seems like there's a cumulative effect, that people may go through some traumas and be fine, get to another trauma, and then develop PTSD. There's also long-term PTSD and delayed-onset PTSD. With long-term PTSD, that comes about from a prolonged use of otherwise normal adaptation responses to changing circumstances. So back to the example I mentioned before, the person has the same responses and keeps using them even though the situation has changed and those responses are not adaptive anymore. There may be secondary stressors. We're seeing after Hurricane Katrina that many parts of New Orleans are not being rebuilt very quickly. People are having trouble finding jobs. People are still living in trailers. The economy is still very depressed there, so these are other stressors that can act on to this and lead on to more of the PTSD. Some people delay in seeking help, and that will also lead to long-term PTSD. There's also delayed-onset PTSD, which develops at least 6 months after a trauma, but it's not very common. The symptoms may fluctuate, so the person may be better for a while and then worse again. And this may last for a very long time if untreated, and a very long time means years. There are reports in the literature of interviewing people 20 or 30 years after a disaster, and they are still showing signs of PTSD that they've never been treated for. Now, with mass casualties, every mass casualty presents unique challenges depending on the nature of the disaster. Survivors and family members will want to visit the site of the disaster, and in that case, there need to be 2 groups created, one for survivors and their families, and one for the families of victims. Each group is going to have very different reactions to the site, and ideally they will not visit the site at the same time. Also, people will need to be prepared before going to a site of a mass casualty. They need to be told what it will look like, what it will sound like, what it will smell like. And when the family is there visiting, then it should be a case where, or policy where the people working there stop just out of a sign of respect and just stay silent for a while where the families are there. Here are some examples of mass casualty sites. The World Trade Center site, TWA Flight 800, train bombings in India, and the 1918 influenza pandemic. And we may not think of a pandemic as a mass casualty, but there were some cities that were hit very hard during that pandemic, notably Philadelphia, where there wasn't a sufficient preparation, and then there was a delay in responding to the pandemic, which caused the number of fatalities to rapidly increase. I think at one point there were over 700 people who died in one day, and the city was just not set up to handle that number of deaths. So that there were shortages of coffins, there were mass graves rather than individual graves. People just had to bring their bodies out of the house to be collected, to be taken away for burial. Now again, with mass casualties, public health guidelines need to be followed depending on the nature of the disaster. If there was an infectious agent, and whether that was accidental or intentional, there may be issues about quarantine and isolation. There are various groups that have been called on to assist. There's the Disaster Mortuary Operational Response Team from the National Disaster Medical System. I'm going to talk now about the modules. Module 1 is called Mental Health Response System and Federal Funding Overview. This covers the National Response Plan, the National Incident Management System, FEMA regulations, the California Emergency Plan, and Standardized Emergency Management System. And that's the first page showing on the slide. Module 2 covers basic clinical principles, best practices, phases of disaster response, intervention strategies, psychological responses, psychotherapy versus disaster mental health, ethics, emerging responders. These are the people who show up at the site before anyone officially has been called in. Disaster mental health team deployment, assessment considerations, initial and delayed responses to trauma, and when to refer someone to professional services. And these are the title pages for modules 2 and 3. Basic clinical principles, and then module 3 is weapons of mass destruction. Module 3 covers the effects of intentional disasters with WMDs. It looks at the biopsychosocial view of the effects of those attacks with those substances. It discusses problems specific to CBRNEs, which stands for chemical, biologic, radiologic, nuclear, and explosive agents. It covers physical and psychological damage to survivors and family members and discusses short and long-term implications of attacks. Module 4 looks at anxiety and related topics, acute stress disorder, other anxiety-related disorders, PTSD screening, group and individual responses to a disaster, unique features of CBRNEs which can produce psychiatric symptoms, pharmacologic treatment for PTSD, and when to refer out for psychotherapy. And these are the title pages for modules 4 and 5. Module 5 is coping among survivors. It also covers medically unexplained physical symptoms, coping skills, long-term psychosocial implications. It goes into more detail on types of coping skills and the effects of coping styles on PTSD, treatment for medically unexplained physical symptoms, or MUPS, the long-term implications of a terrorist attack, chronic PTSD, and disaster characteristics affecting PTSD and long-term physical problems. Module 6 covers delivering bad news. delivering bad news and death notifications, which mostly we are not called on to do. It's usually people from the medical examiner's office who do this. However, in a disaster with many casualties or a mass casualty site, we may be called on to assist in the process along with police officers and funeral home employees. There's also debriefing for medical professionals, mass casualties, and then family resource and family assistance centers. Module 7 looks at risk management, isolation, and quarantine issues. So there's risk management and risk communications, issues around isolation and quarantine, topics and challenges unique to bioterrorism, evacuation versus sheltering in place, enlisting the general public as a capable partner, how the public views government readiness plans, and thinking beyond the hospital for mass casualty care. And that's the title page from Module 7. This is an example of looking at cultural practices and respecting them, but still trying to protect people. During an outbreak of Marburg virus, it was found that the cultural practices of preparing the dead body for burial was actually spreading the virus. So it became a matter, once this was known, of providing personal protective equipment to the people who were taking care of the bodies, the victims' bodies, and preparing it for burial. So they were able to still maintain the cultural practice, but keep the virus from spreading that way. Now, some resources to contact are the American Red Cross, United States Department of Justice, Disaster Mortuary Operational Response Team, National Disaster Medical System, National Transportation Safety Board. Now, most of the information in this talk and in these modules is specific to adults. For information specific to children, you can contact the website www.cphd.ucla.edu and send an email to mschreiber@mednet.ucla.edu. That is Dr. Meryl Schreiber, who headed the project at UCLA, which covered the information for children. There's also the National Alliance for the Mentally Ill, National Center for Post-Traumatic Stress Disorder, and the American Psychiatric Association Committee on Psychiatric Dimensions of Disaster, the American Psychological Association Help Center, and again, the modules here for disaster mental health training through UC Davis. This is the Primary Care PTSD screen, or PC-PTSD. It has 4 yes or no questions which can be given before the appointment or asked during the appointment. Some offices will offer a questionnaire to the patient when they come in. This could be typed up and just added to that list of questionnaires. If the patient answers yes to any 3 questions, that is considered to be a positive result. So ask or have printed on the form, in your life, have you ever had any experience that was so frightening, horrible, or upsetting that in the past month you, 1, have had nightmares about it or thought about it when you did not want to, 2, tried hard not to think about it or went out of your way to avoid situations that reminded you of it, 3, were constantly on guard, watchful, or easily startled, 4, felt numb or detached from others, activities, or your surroundings. So again, 3 positive questions out of 4 indicate a diagnosis of PTSD or probable PTSD. The CAGE is a brief test for alcoholism. C, have you ever felt you should cut down on your drinking? A, have people annoyed you by criticizing your drinking? G, have you ever felt very bad or guilty about your drinking? And E, have you ever had a drink first thing in the morning to steady your nerves or get rid of a hangover, an eye-opener? And I believe with this, it's a positive answer to even 1 question merits further discussion of the answers and the other questions in the list also.